Welcome, everybody. It's Paula Nutting, your musculoskeletal specialist here today. And I'm really, really excited that today I can present to you one of the most amazing educators that are coming from the Northern Hemisphere this time. So we're lucky enough to be grabbing Aubrey Gowing, who is from Dublin, the Holistic College of Dublin. And he and I are going to have a chat today for about an hour. The event is all about interaction. So what it means is that you can actually access the chat box and come on in and type away questions, and we can facilitate the answers to be for Aubrey to answer as much as he can. So it's your time to pick an expert's brain. So hopefully we're going to get Aubrey right now to come on in and join us.
Hi, Paula. How are you doing? How are things?
Good, excellent. How are you?
I'm really good. It's good to see you. Thanks for inviting me on. Really appreciate it. Love the idea of people asking live questions. You know, I always, about these kind of events, the one thing I really enjoy is those real brain teaser kind of questions. So really encourage people to jump in and ask questions. It's going to be fantastic.
Perfect. No, I'm super excited about that. We were talking to Ruth Werner about her topic was Stump the Pathology Teacher. So, guys, it's your chance to actually try to stump the pathology teacher here with Aubrey. So, Aubrey, I'm really interested. Just before we were talking, I was actually asking Aubrey how long he has been involved in teaching and how long he's owned the college, and it was really interesting. It's not just you, it's a background of family.
Absolutely. Like I sometimes jokingly say, you know, I actually started this in utero before I was born because my parents took up yoga when my mom was pregnant with me. That was the only kind of prenatal sort of stuff that was available in Ireland in the 70s. And they got so interested in it. My mom went on to study to be a massage therapist. My dad went on to study to be a yoga teacher and then opened the Holistic Healing Center in Dublin in 1986. And we started learning yoga as kids. So like when I was 4, I was doing breathing exercises, meditation, yoga postures. So it's really something I've grown up with literally my entire life.
That's amazing. So you've been downward dogging for as long as anyone I've ever known.
Literally all my life, yeah. And the great thing about it is the college in its current iteration is run by myself and my sister. So it's really great to have that partnership that we both have this absolute passion for therapies that continues to drive us. Alison actually started the year before me. She started in 88 with holistic massage. I started in 89. And the two of us are absolute therapy junkies that we've just continued to study throughout our career. I think I'm up to about 55 different qualifications and certifications at this stage. So wow. I'm still loving it.
That's incredible. That's so exciting. I love that that even the experts and the people who you think they're at the cream of their crop still do lots of self-development.
Totally. Yeah. I mean, I love learning. Both myself and Alison were in Costa Rica recently with Eric Dalton. I was a special guest this year, which was really exciting. And it was about my 3rd or 4th time there, where it was Alison's first time to go to Costa Rica. She was getting her Master Myoskeletal certification. And we were just saying, you know, we're such therapy nerds that even 30 plus years, I think Alex is about 33 years, I'm 32 years. And we're still really excited. The classroom is still our favorite place in the world to be.
Isn't that funny? Libby Jones O'Flaherty, who's actually, I can see her in the comments section. She is an absolute advocate of yours, and she and I were talking about about how we're going to meet up in Costa Rica and do Eric's course in 2023. So yeah, I think we'll
highly
be safe.
Recommend it. I mean, it's one of those experiences that you'd literally say everything about it is amazing because you're in this kind of like enclosed compound in absolute paradise. The place is beautiful. The people are lovely. There's great trips you can do. So it's not just the quality education, which is amazing in and of itself. It's the whole experience. The people really bond because you're living and working with other therapists from all over the world for a week straight. So it's phenomenal.
Guys, it's Paula Nutting, your musculoskeletal specialist. And this is that awkward, cheesy kind of part of the video where I ask you a big favor. So if you want great content and lots of information, you can see down here in the little testimonials, there's free manual therapy information. There's really cool stuff on necks, shoulders, backs, hips, wrists, arms, etc., etc. I've got amazing Ask Me Anything podcasts and vodcasts that you can get free access to. if you want to get that great content, can I please ask you 3 things? 1, can you please subscribe to my channel? 2, can you hit the like button? And as they say, just smash the heck out of that like button. The more information that YouTube gets to me, the more I can give content to you. And if you can click on the bell, that will also give you timelines for when I'm actually dropping something into YouTube so that you can access it really quickly. So subscribe, like, and click on the bell. And I'm hoping to get you as much great content as I possibly can. Paula Nutting, your musculoskeletal specialist.
I cannot wait. I'm so excited. So did you feel like you learnt much new techniques, or did it cement the things that you probably already know and made them a little bit more easier to use?
I think it was probably a little different for me compared to Alison because I was there working. So the last few times I've been there, I've been teaching with Eric. And I do a lot of the AV stuff as well. So you're doing kind of all aspects. You always learn something. There's always a couple of new little tweaks. I'm quite familiar with myoskeletal work at this stage. So I wouldn't say new techniques as such, but like little twists on things. I find what I learn most from is interacting with the students, with the participants on those seminars, because it's trying to figure out a new way to put something that clicks with a particular individual. So it's not necessarily new techniques, but new interactions that I always still learn from that I like.
Okay. Yeah, that's cool. Which kind of brings me into the next part of this. Well, actually, the start of it was because the things that we were talking about is a passionate play for this hour is virtual training experience. Because right now with lockdown, people still want to learn. You've just said, you've got 30 plus years experience and you want to learn. So now we've changed the ball of the playing field to having to learn things in a virtual format. Now, I saw that you were talking about that there's ways that you could improve the quality for students and for educators. And I'd really like to pick your brain about that because I don't know, you probably know my background is I run virtual life courses as well.
Yeah. Well, I do think that there's kind of a couple of things that people can bear in mind. I think the virtual experience can be phenomenal. And I know there's been quite a resistance to this pre-pandemic that a lot of people were saying, therapy is hands-on, training has to be hands-on. And I can see the logic to that because there's stuff you can do in person that you can't quite do virtually. Like one of my favorite things in class is to go around and put my hands on top of the other person's hands, tell them to relax so I can feel the tissue texture, and then they get that experience, when they're particularly in the early stages of learning. So I think when you're starting out, particularly at foundation level, hands-on is essential to get those kind of tactile feedbacks, the checks on pressure, all those sorts of things. But once you move into even slightly more advanced training, there's a lot you pick up visually because you have a lot of the kind of touch tools. You understand about sinking into the depth of resistance within tissue, what's an appropriate pressure, all those kinds of things. So a lot of it then is kind of learning just new positioning, different tools for practice, if you like. Yeah. And the one thing that I've really found with the virtual experience is if students engage in the same way that they do in class. So particularly like say when we do our myoskeletal weekends or any of our corrective manual therapy classes, we encourage students to have somebody there at home that they're working on, turn on their camera, and we can actually give feedback. So they not only see us, we can see them. And I'm oftentimes saying to people, yeah, you need to step a little closer, your elbow's too far forward, you need to bring that back, whatever it might be. You can really coach people on positioning, body mechanics, placement, where exactly making sure they're in the right spot on the person they're working on. So there's a huge amount that can be garnered, particularly for the more experienced therapists from the virtual world. So I'm a big fan of that. Engagement, turn on your camera, ask questions. So I really think this is a big thing as well. One of the things that we use is we'll have a producer. My brother Tom actually does a lot of our producing for us. And it means people can pop stuff into the chat that you oftentimes have people that are maybe a little bit self-conscious about asking a question in a big class. They either don't want to look foolish or they're not comfortable public speaking, even though it's not overly public. They feel so self-conscious, they don't want to ask the question. So they get to type that into chat. And the producer then can pop that in at an appropriate time. When there's a little bit of a pause in, I don't tend to pause that much. I talk a lot when I'm teaching, but there's times when you're focusing on what you're doing. And Tom will oftentimes pop in with a question then saying, oh, so-and-so had. And you get to ask follow-ups as well. So it's a hugely interactive experience from the participant's point of view. From the presenter's point of view, I find that you are, because you're kind of talking to camera. Now, we've done a couple of different versions of this. We've done hybrid seminars where we've people in the room and we've people at home. And then we've done some seminars where they're purely virtual.
Yeah.
But in the hybrid, people always say like they feel like they're in the room because the camera always has the best view for starters. And then when the other people are practicing in the room, we'll oftentimes have teaching assistants going around, and I'll actually be talking to camera, showing people, well, if you don't have somebody to work on, here's a way to apply this as a self-care treatment. So we'll look at, if you're going to work this yourself, here's how you can get the angles, you can do self-treatment. So people still get to work.
Yeah.
But in the purely virtual as well, what I find is talking to camera, it's like, I remember, I don't know if you guys have heard of the Scottish comedian Billy Connolly.
Oh, yeah.
What he used to talk about when he was doing a gig, he said, I love when you bring the crowd together to the point that you feel like you're talking to just one person. It creates that real sense of intimacy and community at the same time. And doing the virtual events is a bit like that, because when you're talking to camera, it's like you're talking to each person directly. So there's a really strong connection and rapport that you can establish through the virtual that I think is harder to do in a big class, because you're trying to make contact with so many individuals and it's not quite the same experience.
Yeah, I absolutely agree. And if there's anyone out there who are educators and are thinking about doing courses online, then those are salient words, that they're things that we should be all doing. I know with the courses that I run, because they are virtual live, like, a 3-hour once a week or whenever they are, we always make sure that you get the information. It is that one-on-one. We'll run through maybe the PowerPoint just so that they feel like it's a familiar, as if they were sitting in front of a desk doing that whole feel of listening to and watching. And then we drop into a couple of videos, and then we do the experiential thing. Have a feel of what this is like. Now go through that range again. So you have to be smart. You just can't not be flippant and lazy. It's not just PDF files and chatting through. And I like that Tracy's just said down there, and that you can ask lots of questions. And she's right, because you're saying that anonymity. You feel safe just tapping.
Yeah, absolutely. And even the group chats that get going as well, like it's amazing the sense of camaraderie that people in the virtual environment can develop, because they can be chatting amongst themselves offline, which you can't do in a real class because it's disruptive for other students. Whereas typing in information, no problem at all. And it's interesting where you say about like not just using kind of like static stuff like PowerPoint as well. One of the things I really like doing is using some of the augmented reality stuff. So people can see as though you're looking through the device, like say on an iPad or something, we'll use a 3D for Medical program or something, and we'll show the anatomy. We'll be able to place it in the room, look at it on the table, go through layers, all that kind of stuff. And when you're watching that at home, it's like you get that, again, first person view. So it's really, really impactful and really engaging. When people see that augmented reality stuff, when they see like an anatomical representation standing in the room or lying on the table, it just has that emotional impact. And they always talk about emotion as being a big driver for memory. So it really helps people to connect with the information and to retain it.
Yeah. And anyone who's listening to this, I urge you, go back and just look up Aubrey Gowing. And I think there was one on plantar fasciitis and talking about the foot, like just or a neural entrapment or something, because it was really clever. And, just talk about that, bang, it's straight in my head. The patient lying, augmented lying supine, and you're just going through the feet.
Yeah, and you can see the anatomical structures in 3D. And what's great is we can oftentimes get in front of the camera and point to stuff and go, you see this here, this is the plantar fascia, and over here we have the, like you're saying, the tibial nerve coming down or something. So people get to have a very, very clear, very vivid visual of the structures that you can palpate, but you can't see. So it gives it that, again, another dimension, another depth of understanding, I think, that's hard to reach in different way, in any other way.
Yeah, virtual wet lab.
Yeah, exactly. Without the difficulties of actually having to do cadaver work. Yeah.
I know. We've all been there. So, and it's one of those things that you take students to wet labs and they come out and it's like they've had this bulb that's just brightly shining, and they go, I didn't ever realize that the piriformis was actually quite impossible to access because of all of that gluteus maximus, all of that deep muscle, and people that are saying I'm palpating it by tapping at that depth is, yeah, it's not actually reality. Libby's just saying augmented reality. Now, how does, if you're an educator out there, how do you make that a great experience for them? How do you give them tips and skills to, like, have you've got other people who are teaching at the college?
Yeah, yeah. One of the things I find with the augmented reality is it can be a great time saver because you can set up images the way you want them ahead of time. You can actually store them in a library in some of the apps. The particular one that I like, a lot of people have probably heard of at this stage, it's called Complete Anatomy. It's actually developed by an Irish company. I mentioned 3D for Medical. They've a range of different apps, but Complete Anatomy is particularly good. And when you use that augmented reality, you can preset the things you want to show. And then when you bring it into the augmented reality, like basically it uses the camera of your device and it overlays their anatomical structures. So like
Yeah.
literally you can lie a body on the table and you can have it pre-dissected, if you like, to show nerve pathways or blood vessels and their relationship to other muscles. So that stuff can be really, really interesting.
Yeah, it's super smart. So anyone who's thinking again about this kind of stuff, that Complete Anatomy is amazing. There's quite a few people I know that are using that just in their clinics to explain to their patients when they've complete what they want to be doing with them. So if we're looking at somebody sitting down, I remember having to do it, and I'll never ever do it again. I had to do an 8-hour, a full weekend, virtually. So I was supposed to be in Perth, and we were locked down the weekend before.
Mm-hmm.
And I had all these people going to the course clinic. So rather than me cancelling everybody, we just got a large screen, and we had the person that was in charge of it walking around with the video camera.
Mm-hmm.
It was the most exhausting thing I've ever done, trying to teach for 2 8-hour days and going, okay, like just put your laptop a little closer. I just want to have move your fingers a little bit. You know.
Mm.
So you talk about micro modeling or micro models.
Yeah, because we actually did the same thing in January of this year, actually. We went into complete lockdown here in Ireland and we had a myoskeletal seminar on, and I did 3 8-hour days in a row, 9 hours including the lunch break, so 8 hours of teaching. And we found it great. Because the interaction with the group, we did exactly the same thing. We had a camera so that they could see us, but then we had a big screen with the individuals on it, and we could give them feedback. And it is a lot of work. I don't think maybe people appreciate that from the presenter's point of view, that it's like a live performer saying that they don't have the audience. So that part of it can be a bit exhausting. But I found it really good. I enjoyed the experience. But yes, leading on to our micro modules, the flip side of that, the easy way to do that, I think, is these kind of like short bite-sized kind of pieces. So we started off developing these. We did a series called the Essential 8. And this kind of came about from chatting to students in class and saying, what were kind of the most important muscles to treat in each part of the body? Now, it's very hard to say what's the most important because, everybody's different, all that kind of stuff. People do different movement patterns. But we were narrowing it down and we were saying, well, there's oftentimes, if I had just one muscle I could treat in a particular body part, the one that is most predictably dysfunctional, so the widest number of people are going to need this muscle treated, but also that it contributes to the greatest number of dysfunctions.
Yeah.
So an example of this would be, say, posterior tibialis in the lower leg. Posterior tib causes an imbalance in the stirrup system that stabilizes the foot. So it leaves you more prone to lateral ankle sprains. Because its antagonist is anterior tibialis for dorsiflexion, plantar flexion, it leaves you more prone to shin splints. Because of the direction of force, it can cause talar shift, which can jam up the ankle, leave you more prone to syndesmosis type sprains. It can tension the tarsal tunnel and cause things like it can mimic Morton's neuroma. So it can drop metatarsal heads. It can affect the arch of the foot. It just is so broad in the number of things it can have a negative impact on. We said if there was just one muscle I could treat at the lower leg, it'd be posterior tib. So we went through the body. We broke this out into 4 1-hour modules. So there's 2 muscles in each one. And we talked about what would be the thing to treat for knee conditions. What would be the thing to treat for low back pain? What would be the thing to treat for the neck, for the shoulder, for the arm? And that really is a very manageable way for people to take in information, because The way we generally approach these with the micromodules is we'll talk about what the condition is, why this muscle is so important. Then we'll do assessments. So you're not assuming that the person has this thing. You're actually able to test and validate, yes, okay, this client does have difficulty or dysfunction in their posterior tibialis or maybe even injury. Then we go into the treatment phase and we show how to address dysfunction within this muscle. And then we do home retraining as well. Is it weak? Yeah. Is it tight? Do you need to stretch? Do you need to strengthen? So it's very, very targeted. We also reassess at the end as well. So you know, are you stretching or strengthening? That we're not just assuming that a muscle is tight. People talk about this a lot with psoas, for example. People will say, well, not everybody's psoas is tight. Some people's psoas is weak. Not everybody should be stretching their psoas. And I go, yeah, but most people should. Evaluate and see. If it's tight, do stretch it. Weak, do strength train it. So these are very kind of targeted micro modules that people can go back to time and time again, but it's like 1 hour of study. And to me, the most important part is it has that unbroken chain that I think is really important for successful treatment outcomes, that you understand the condition, you know what assessments are relevant, you know how to provide treatment based on that assessment, and then based on the outcomes, what kind of home care you need.
Yeah.
That to me is the real start to finish process.
It is. And I think that that's kind of a part of that thing that you were talking about is like making a roadmap of how, and you know, there'll be people out there that will be going, what treatment do you do for tib post? Like I can guarantee you there's people out there going, oh, do I strip? Do I stick needles into it? What's like, you know, so you can't give that little nugget without giving them a couple of maybe, do you have 2 or 3
sample kind of things we could say? Okay. Yeah. So typically posterior tibialis is going to be, we would describe it as short, tight, and facilitated, which actually is describing different things. You know, it has lost extensibility. Now, not always, because sometimes people have a low arch. It can be kind of bound mid-length, that it's not really shortening very effectively, but it's not really lengthening very effectively either. So this is where the assessments come in. Yeah. But it's rarely completely overstretched, weak, and inhibited. Posterior compartment muscles and deep posterior compartment muscles are typically tight. So short, tight, and facilitated. Short meaning they've lost extensibility. Tight meaning they have elevated tone, or their fascia, the actual layers of fascia have become too stuck together from lack of variety of movement. So we've lost some of that slide and glide. And then facilitated is more to do with how the nervous system is controlling tone within that muscle. So it means it usually has elevated tone. It's being, like, if you think to facilitate is to encourage, to help. So it's being encouraged to work nearly too well at the expense of its antagonistic muscles, which are oftentimes then, the flip side of that is they are inhibited. They neurologically are prevented from developing enough force to counteract what's happening in posterior tib. So typical, one of my favorite techniques, and it's hardly a technique, it's so simple. We did this in Costa Rica and it blew people away. I was saying simply pumping the tissue to create a nervous system response, that the nervous system stops guarding, the tissue starts to soften. It also creates an increase in hydration. Robert Schleich demonstrated this a couple of years ago in the University of Ulm. They talked about measuring the actual fluid content in tissues. And they said just from simple pumping, there was a 2% increase in fluid. So it was phenomenal. So I talk about this kind of just pumping nearly to settle down the nervous system. Then once you feel that kind of hydration, you start to move the tissues. And you can work right down to muscles like psoas without any pain. When we did this in Costa Rica, the person on the table had that real pinching on extreme hip flexion. They had weakness. They had all kinds of psoas dysfunction. And as we worked our way down, when we got to psoas, it's like, on a scale of 1 to 10, what would you rate your pain as? And she was like, 0. And this is with her legs straight. We worked our way down in about 3-4 minutes. We actually, I think somebody posted some of these videos on Facebook, so you can probably see some of these on, I think, our Facebook page, where we're working down through psoas. So we do something similar with posterior tib, where we kind of get in around the back of the tibia, we pump the muscle, we stretch to mobilize the fascial sheets. We'll oftentimes do a bit of soft tissue release, some active isolated stretching, or some MET. You can use those kind of interchangeably. But that's not to say that those things are exclusive. You mentioned about needling. I personally, I'm not a big fan of dry needling, and I don't want to offend anybody.
Thank you.
And I always say to students, it's personal preference. You know, there's nothing wrong with dry needling. I would just think I would rather work layer by layer, because this kind of comes to some of our overarching principles. I'm always going to work from superficial to deep. Now, needles can be a quick way of shortcutting that. So I'm not against the use of needles. It's a personal preference. I know what people come on going, you can't say dry needle. It does work. I'm not bashing it at all, but I'm just not particularly a fan.
You
I sound
always
quite
like
excited by that, Paula. What's your take on it?
no. Look, I think that if you've got something that is giving you an alarm that you can palpably find, you can palpate, bang, there's your alarm bells. It's like a stop sign. Why would you remove the stop sign at the start of a program, like the start of treatment, versus leave it there as a guide and then do your other techniques and go, is it still there? No, it's not. So it's not the cause, it's a symptom. And then we pull back to find it. No, I'm not a fan on. I can do myofascial dry needling. I'm qualified in it. Do I do it? No, I don't. Yeah, I don't need to. I don't need to. But I do like the fact that we're working on the nervous system. Lots and lots and lots of practitioners now are swaying towards the nervous system as the first point of call in a lot of cases to, calm the nervous system down or to stimulate it. So that I'm loving that. It talks about maximizing learning. So you did 1 hour times 8. Where you pack
times 4. Yeah, I was getting ahead of myself. There was 4 of those micro modules. We call it the essential 8, but it's actually 4 modules.
Yeah, incredible. And I get that it's about a quick reference library. By building these up means that people just have them kind of set that this is not easy to do, but this is something that I can apply quite effectively in my clinic. And I suppose, and I'm noticing that for an hour, most people are going to hang around. Most people aren't kind of drifting off somewhere, like you see often. But I want to ask about complex conditions because tibialis posterior is not something that a lot of therapists would automatically consider. That's just not where they go. They go, oh, maybe the gastroc or the soleus or the Achilles or something. But in actual fact,
posterior tib can oftentimes be the culprit. And this again comes back to some of the overarching principles that we keep coming back to time and time again, because I think if you understand principles, you can apply them anywhere in the body. And one of the things we talk about is working from superficial to deep, but also superficial muscles tend to be less dysfunctional. So I actually find in clinic, gastroc is the least dysfunctional, soleus is a little bit more, and posterior tib is the most dysfunctional. So you tend to find that as you go deeper, you find more stuff. And that's the relevance of deep tissue work. Unfortunately, deep tissue has become synonymous with aggressive, painful manual therapy, which it really shouldn't be. It just means accessing the deeper tissues. And again, if you work layer by layer, particularly using that kind of pumping, mobilizing, stretching the tissues, using whatever techniques you're used to using, myofascial release, soft tissue release, whatever methodology you're using, but go down at a layer that the nervous system is happy with. We talk about never exceeding 4 out of 10 on a pain scale. So we'd say strong enough to be effective, but light enough to be pain-free. That's our Goldilocks zone. Kind of 3 to 4 that the person says, I feel it, you're on it. There's maybe a little bit of sensitivity, maybe even discomfort, but not pain. I talk about this in my book, actually. I talk about, what are the key indicators? Because people will have different kind of perceptions of pain. Sometimes you'll have people going, oh, that's like a 4. And you're going, that's a lot more than a 4 if you have that kind of response. So we talk about, well, what are the recognized markers? So it is about what the person says. That's a valid subjective interpretation of their pain. But then there's objective responses as well. So there's things like the person flinching away. There's the change in pitch of voice. There's the change in their breathing, the kind of squinting. I mean, you've probably had this experience. The client is nearly asleep on the table. They're snoring. They're like, and they'll give this, they'll twitch, their eyes will flutter, their eyebrows will go. They will show visible signs of distress, that it's starting to tip over from discomfort into pain. So I talk about, like, what do you see at kind of a 3 or 4? What do you see at a 5 or 6? What do you see at a 7 or 8? What's a true 9 or 10? Because I've had some clients and they just don't like any discomfort. And you're pressing on the tissues and they're like, what's that on a scale of 1 to 10? They're like, oh, that's definitely a 10. And you go, you're so calm. There's no sign of distress. You just don't like discomfort. So I talk about, like, how do you recognize these kind of markers of, what is genuine pain? When is it getting to be too much? When is it really alarming the nervous system is the big thing. And if you don't alarm the nervous system, you'll be surprised how quickly you can get down through those layers, alter tissue texture, that those tissues are actually much more functional as a result, and really change the muscle balance, change what the nervous system is doing with those muscles. It can be a very, very quick process.
What's your
But yeah,
take on comments and I hear it, I've heard over the decades loads of times. Oh my gosh, that hurts, but it feels like it's so good. It feels like it's doing something.
yeah.
That's got to be working at the nervous system. But are they working at? Do you unpack that into something that if they like pain
Well,
versus not? Like,
when they go, that's sore, but it feels really good.
hmm,
That's actually what I would call good pain.
yeah,
That is where it is really about 4 out of 10, maybe even 5 out of 10, where it's strong enough to really draw the brain's attention to that area. So the brain is really focused on what's going on. The tissue change that you're creating is a positive thing, that you'll have clients even in on a first treatment and they'll go, oh, that's it. That's what I need. Oh, that feels so good. Because they recognize unconsciously, they don't know anything about the techniques you're doing. They don't know the physiology. They don't know the structures, but their nervous system knows what it needs.
yeah,
So that's the kind of person who'll say, it hurts, but it feels great. You're really getting to where it needs to be. That changes once you get into the kind of 7s out of 10s, 8s out of 10s. They won't be saying that's great. They'll be gritting their teeth. Now, unfortunately, because aggressive manual therapy was such a thing for so long, still being practiced, still being taught in some areas, unfortunately, but clients then have this impression that it has to hurt to do them good. It's a bit like the old, training adage of, no pain, no gain. And they prove that's not true. So, sometimes people are a little cruel and they say, no pain, no brain, where you'd say, if you want to be hurt that much, you really have to, I think, re-educate your clients to a certain extent.
yeah,
And I've never had a client, I don't do aggressive manual therapy, never have. Even from the start, my tendency was always to be light. And for quite a while, I went through this fascination with how light can I go and still be effective? I was trying to be minimally intrusive. That's changed. I mean, I still do a firm, strong treatment. And I've never had a client say, you didn't go heavy enough, or you can go heavier. Within 5 minutes of being on the treatment table, they're feeling the change and the improvement and you not hurting them.
yeah.
They buy in straight away. And I haven't had a client get off the table going, you know, wasn't really that good. Because I've had students come back and say to me that they have difficulty with clients that are, they nearly feel like they have to inflict a little bit of more extreme discomfort just for that person to feel like something was done, for them to be satisfied with the session. And I think that if you are working at the right intensity, again, strong enough to be effective, light enough to be pain-free, the client will feel the benefit. They
Yeah.
will get to the point that they realize, oh, it doesn't have to hurt. It can still be therapeutic. It can still be beneficial. And I'd even
And
say those times when it is sore, I would say it should be momentary, mild, therapeutic discomfort. If it's all of those things, it's fine.
and new students, new therapists in the industry, they haven't quite learnt that how deep is deep enough that you can feel a sense of where the tissue's coming back at me. And that's where I think they're worried about their touch, which is they're being interoceptive to themselves. They're not actually working with the patient on the table. So they actually don't have that connection. And part of that connection, I think, is when the patient says, you can work harder on me. And it's almost like a cry for, I want you to connect with me. And sometimes it's about saying to the student that the more times you can get your hands on people, even if it's just massaging your dog, and just get a feeling of what it feels like. We have to learn how to work these things. It's not like jumping into a Tesla and expecting to take off.
Yeah. Well, one of the things I talk about a lot is body mechanics, that I think if you're using body weight, you can get intensity without necessarily, actually, intensity is an interesting point because we don't talk so much about pressure in our school. A lot of people focus on pressure, pressure, pressure. And I would say really it's more about intensity. And pressure is only one of 4 elements that contribute to intensity. So you have the area that you're using, the angle, the pace, and then the pressure. So pressure gets you to the required depth. So there's other things you can change to make it more or less intense. If you use a broader surface area, pressure is dissipated, it's less intense. Smaller surface area, so you don't have to go any heavier. If the client goes, can you go deeper? Switch maybe to the pads of your fingers, or even the tips of your fingers. And it can feel an awful lot deeper and you don't have to go heavier. So it's not strenuous for the client or for the therapist. It's not damaging tissue for the client. Changing the area is one, the angle is another. So if they say it's too sore, instead of dropping your pressure, drop your angle, because then you've still got depth, but you've reduced the intensity. So I talk about these almost like dials you can adjust, or I think about like the old what do they call the equalizers on an old stereo. I don't think you see those anymore. That you can dial up and dial down. So you can keep the pressure, but dial down maybe the angle that you're working at, or slow the pace. To be honest, if somebody says something is starting to creep above a 4 out of 10, the first thing I'm going to do is slow down.
Yeah,
Particularly with something like a soft tissue release, do the movement more slowly, and it's tolerated a lot better. So I'm going to adjust the other 3 elements, the area, angle, and pace, before I adjust pressure.
yeah.
And if you do that, you can really moderate intensity and get to the point that you're really being effective without straining yourself and without hurting the client, but using good body mechanics, leaning into the treatment, literally committing to the technique. And as you said, communicating through touch that I'm literally getting behind this technique. I'm prepared to put my weight into it. I have that much confidence in it. That comes through to the client, and that creates a really positive experience.
Yeah, and that's it. Well, there's more and more studies on it that the placebo, which is not a dirty word, that placebo of coming into a client and coming into your therapist and knowing, I had pain this morning, and then I knew I was coming to see you, and for some reason it's half the pain that I had before. So that's
just seeing an interesting question coming in there. Somebody's asking, what should I do if I always have a stiff neck? I always feel like cracking my neck. That's a really interesting one, because people talk about, is cracking joints bad? Not bad at all. All it does is it creates more space within the joint. As a result, you have the same volume of fluid in a bigger space, so pressure drops. Now, there was an Irishman, Boyle, discovered this, that there's the Boyle's law, that at different pressures, gases will fall in and out of solution. So when you reduce the pressure, the gases that were in solution in your synovial fluid fall out of solution and form an air bubble. And it's that forming of the air bubble that creates the recognized crack. That does you no harm whatsoever. There's a doctor, I have the name somewhere and I can't remember. You may have heard of me, cracked the knuckles on one hand every day from the time he was like 5 or 6 years old, because his mom said, that will give you arthritis. And he cracked the knuckles on one hand and didn't on the other. And he said now, 63 years later or something, he says he's more mobility in the hand that he cracked every day.
Oh, my grandmother would be going, you get arthritis if you crack your knuckles.
Doesn't do it at all. Now, the one thing I would say is, when you feel like you need to crack your neck, there is irritation there. There's tight muscles compressing the joints, and they feel like they need a release. So the feeling like it needs to crack is actually, like you were saying about the stop sign, it's a warning to you. There's something going on in this area that needs attention. Cracking the neck won't do any harm, but it won't alleviate the problem. You need to address which muscles are tight. And quite often it's actually the scalenes. My one muscle in the neck, we talked about posterior tibialis in the lower leg, my one muscle in the neck would actually be anterior scalene. Because it affects rib movement, it affects breathing, it affects rotation of the cervicals, it affects the thoracic outlet, the entire nerve supply for the arm. So when those muscles are tight, usually you have a dominant side. Most people are right side motor dominant, and it will rotate the vertebrae a little bit. So they're not in ideal alignment. When you crack the vertebrae, it'll help, it'll change neural input a little bit, but the muscle is still tight and it'll pull it out again. So oftentimes doing some simple kind of like pin and stretches for your anterior scalene, talking about self-treatment, or stretching the anterior scalene. And the best way to do this is you actually side bend and turn in opposite direction. So if I'm going to stretch my right side anterior scalene, I'm going to turn my head to the right, but then side bend left. And you'll feel this come down almost to the back of the collarbone. And I recommend Aaron Mattis's active isolated stretching. So you stretch for 2 and come back out. Another 2 seconds and come back out. When you get used to this, you can add just a tiny little bit of overpressure. So you don't want to go cranking on your neck, particularly with that rotated and side bent in opposite directions. That's known as non-neutral spinal mechanics. So you don't want to be jamming on your neck at that. So like, you notice I'm using a fingertip, just because these muscles aren't necessarily strong enough to overcome the tense ones. So sometimes these guys will help by activating these. You'll reciprocally inhibit the muscle you're trying to stretch, but you may need to get a little bit more lengthening with a very gentle assist. So stretching the neck muscles, get to a therapist, get some treatment. That should stop you cracking your neck.
Exactly. So how do we learn the difference between what is a simple condition and a complex condition, because we get patients or clients are coming to see us and they might come back time and time and time again with a shoulder pathology or lower back, and they go, it's good for a couple of days or a couple of weeks, and then it's back again.
Yeah, that's my real interest, is kind of getting to the core of a problem. And I mean, looking at this in a very simple way, we talk about people who have a forward shoulder posture, and they would say, oh, I'm really tight across my back. And the answer is, you're not tight. Those muscles are overstretched, they're weak and inhibited. And the interesting thing is, it's more often the weak muscles that are pain generators, because they're really stretched out. I describe them as being taut. You think about like a guitar string being wound taut, you can twang it. It's not short. So the problem is with the vocabulary, when we think about a muscle being tight, we think about it being short. So people start going, oh, I must stretch that. In a yoga class in Costa Rica, Ali was saying, the yoga instructor kept going, and stretch out your tight upper back muscles. And you're like, the only person who should be doing a rhomboid, infraspinatus, posterior deltoid stretch like that is somebody with retracted shoulders. So if you see people walking around with this posture, that's the person who needs to do that. But most people are the opposite way. They're forward shoulder. So looking at treating flexors first, treating tight muscles before you can successfully address weak muscles, is one of our core principles. That can demystify some conditions for people. When we talk about a complex condition, it's usually that there is a layering up, that the person may have had an early injury or maybe just overuse, and then the body has gone through an adaptation. Then the adaptation itself starts to cause an adaptation, and then you get a further adaptation. So you get this kind of layering up, and that's what really makes a complex condition. Or when the person has more than one thing. We talk about doing muscle resistance tests. And initially the person might indicate that they have a myofascial restriction. So let's say I'm testing pec minor. Bring the arm up 135 degrees, bring the arm back, have the person push forward. So they're engaging pec minor. When you do a muscle resistance test, it's important not only to know how to do the test, but how to interpret the results. So what the client indicates tells you a lot. There's 3 primary things. Well, 4 if we count a false positive. I'll come back to the 4th one. So the first one is a myofascial restriction, when everything is just a little bit stuck. And in that case, when they test, they'll point to the muscle you're testing and they'll move around. They'll indicate the vicinity, the length of the muscle, because usually it's not a point, it's an area of the muscle that is adhered. The fascial layers are stuck and it feels pulled and uncomfortable. And they go, yeah, I'm feeling that here. Then there's a tear. If the person actually has a tear, the tears are very small. So when you test them, they'll put their finger on a point and they'll go, oh, there, it's sore there. It's very definitive. If it's neuromuscular, or if there's kind of nerve impingement, they'll usually point to the structure, but it will radiate along a known nerve pathway, or a dermatome, myotome or dermatome, most likely dermatome, which is just a section of skin supplied by a particular nerve. So they'll indicate kind of a known referral path. The 4th thing is they'll say they feel it somewhere else, like, oh, I'm feeling that on the back of my shoulder. That's a false positive. Yes, they're feeling something. There's something there, but it's not to do with the muscle you're testing. It's not a pec minor problem per se. But what we find is, once we do treatment and we do some myofascial release, there may be an underlying issue as well. So when you test it, they might initially go, it's myofascial. You do your treatment and you retest, and they'll point to a spot going, oh, there's actually a tear there as well. So sometimes with complex conditions, you have to go down through the layers. You have to normalize tissue texture at each layer and treat each type of dysfunction. But then, for that again, I wrote an article recently for MMA's magazine on the knee, complicated knee conditions. And I was saying, there's so many pain generators in the knee, and almost all of it comes from a tight, short head of bicep femoris. It's generally rotation in the tibia, because that messes up the ligaments. It messes up the patellar tracking. It puts pressure on bursa. It causes so many problems. It puts pressure on points of the meniscus, and it's one cause.
Yes,
so that's a lot of what we look at with our treating complex conditions in our corrective manual therapy classes. We actually look at, well, what's the common thing that will contribute to all of these different things? In that article, I actually talked about 15 different potential pain generators in the knee, how to test for them, and still come back and treat posterior tib and derotate the tibia.
Yes,
that's the roadmap. That's the shortcut. That's what we talk about a lot in our classes.
I could get that. So Marfe's had the follow-up question for our poor girl with the do I crack my neck or not? Commenting about will a chiropractor help?
So yes is the simple answer. I would usually say though that these things, unfortunately, these divides that exist within our industry of your soft tissue, your joints, you're an osteo or chiro, you're a myotherapist, you're a massage therapist, whatever it might be. The body doesn't separate that way. One interacts with the other. So what I used to find prior to doing myoskeletal work, where there is a lot of joint mobilization, not to the point of manipulation. We don't do high velocity thrusts. Not that there's anything wrong with those. They get a bad press because I think if you have tight muscles and you go to a chiropractor and they crack out the neck, the positive outcome may be that you change neurological input and that allows the muscles to relax. But if the muscles are tight from something else, from some other guarding or for some overuse, some activity you're doing, they tighten up and they lock the joints again. So you're going back to the chiropractor again and again to crack, crack, crack. The underlying cause is not being dealt with.
Yeah.
Equally, if you go to a massage therapist and they treat the muscles, but the joints are locked up, their muscles keep tightening up to protect this dysfunctional joint. So this is where I think myoskeletal alignment really brings those two together, where you treat the soft tissue and you mobilize the joint. If that's outside the scope of your practice, I would say go to a massage therapist to have the soft tissue work done, and then go to a chiropractor. That's the perfect blend, because then you're getting the soft tissue and the joint work. Before I was doing myoskeletal, I used to send people to a chiropractor who was a friend of the family, and he goes, I love getting your clients. He said the word he used was, their joints are buttery. It's like they've been pre-oiled or something, that they can just slide into place because the soft tissue work has been done. The original cause of what was pulling on those bones has been removed. So all he has to do is get the bones back. There's no muscle resistance to that the way he would experience with a client who's just coming for chiropractic work. And equally, he would send people to me saying, these people, their muscles are too tight, I can't move the bones. Can you treat these muscles? And then I'll send them back to him. So that actually works really well, the combination of the two. But I think sometimes pure soft tissue work on its own can fall short. And sometimes chiropractic work or osteopathic work on its own can fall short. It's the combination of the two, soft tissue and joint work, is phenomenal.
And the more therapists out there that get the opportunity to do joint mobilization techniques, you'll just increase the quality of your outcomes dramatically by linking the two. I've been doing that forever, and I think there's so many of us that are now starting to learn that once you've, maybe not in the Certificate 4 program, but in the diploma, they start to learn a little bit about joint mobilization.
Yeah.
And the value is, again, we're coming back to the neurological system, aren't we?
Absolutely. Yeah. Because there's a huge amount of both nociceptors and mechanoreceptors around a joint. And there's a really interesting interplay between these two types of nerves. Nociceptors are really kind of threat receptors. They're telling you the joint isn't in a good place. For years, people have simplified this and said nociceptors are pain receptors, which isn't really true. They're telling you there's threat, there's a problem. Mechanoreceptors actually dampen down nociceptive response. So the more you move, the less threat you feel. Isn't that interesting? And one of the things they say that causes increased pain as we age is actually that we lose mechanoreceptors. We don't lose nociceptors because we really need to understand threat. But then because there's less of a turning down of the volume, as we lose mechanoreceptors, the nociceptive signal becomes stronger. Now, that's not bad news for the aging process. What it means is, as you age, you should actually start to move more, not less. Stimulate the mechanoreceptors you have, and you will have less pain.
Yeah. Move it or lose it.
Absolutely. Yeah. It's simple. I mean, we know these things, but we don't always implement them. But understanding the science behind it can be really informative as well. But I totally agree that moving joints, I found when I started doing joint mobilization work that conditions that would take me maybe 4 to 6 sessions to really see significant improvement with, I would actually be seeing in one session. So, I mean, talk about shortcutting the treatment time. It's unbelievable. And sometimes people think then, oh, I'll be less busy. Is that not a financial disadvantage? Quite the opposite, because you successfully treat somebody, they'll send in everybody they know. And I don't do as much clinic work now, but I used to be booked out 6 months ahead of time. So doing really effective work is not a bad thing.
No, exactly. That's I get that. So tell me about your college, your virtual classes, the CMT.
Yes. Yeah. So we're doing these kind of every 2 months. Yeah. We're picking different subjects for these CMT classes. And invariably what we'll do, people can go onto our website, it's hcd.ie. And if they go to the CMT classes, they can oftentimes watch or go onto our Facebook page either. You'll see there's like a 4 or 5 minute anatomy review that we do. So it's a good way of kind of getting yourself interested in, is this something I want to do? And then in the live class, we actually will broadcast. I've actually been talking to a couple of people in Australia. So we're looking at maybe doing one that will suit Australian time zones. Might start doing that in early 2022. But at the moment, what we're doing is they're usually evening time here in Ireland. So that's going to be very early morning for the Australian audience. But it's a live class. We do about an hour and 15 minutes. We go through that process of an overview, talking about what the condition is. And then we do the anatomy review live, and then we do assessment, treatment, and home retraining. But then we always allow a little bit of time for live Q&A as well. And you get access to that recording if you sign up for the module. They're €50. I'm not sure what that is in dollars. But when you sign up for the module, you actually get lifetime access to the recording afterwards. So you can go back. This is the thing of like building up a reference library that we were talking about.
Yeah, excellent. Because we've got therapists out here. I'm just looking at Tracy going, yes, all those all-nighters are a killer. And they are like the time zones. We're trying to work out how I can make this work. So we've got 5 a.m. for the Eastern, like Florida, 8 p.m. here for me, 10 a.m. there for you. But that's right, you do an hour. But if you've got 3 hours or whatever, it is a bit of a killer. So that's
why I like those being really kind of condensed, concise, just giving you what you need as a therapist. I think as therapists, we tend to be kind of technique junkies. So it is like, here's what to do, start to finish, just for this thing. And it simplifies things, because otherwise when you go, there's so many things it can be with the knee, there's so many this, it can be with the wrist, there's so many things in the ankle. And you go, well, here's one of them. Let's take an in-depth look at that on its own. And people will even see the commonality. I mean, two of the ones that we've done so far was talar dysfunction and plantar fasciitis. And the treatment you're going to do for the lower leg is pretty similar. But then there's the specifics for that condition, assessing that condition, recognizing if the person does have it, recommending the home care, all that kind of stuff. It just gives you that, like I said, tight focus, something you can really have a bite-sized piece of information that's really digestible that you can then take to clinic and use with your clients.
Now, are these library, like if I've got a couple of patients have come to see me and they've both got something that's going on, I'm recognizing it's probably tailor related. Can I go into the HCD web space and go, there's one, and then buy that?
Yes, yeah. So you'll see on our homepage, when you go to hcd.ie, you'll see plantar fasciitis and talar dysfunction are still up. The Essential 8 is there as well. So that kind of covers, like I said, my top muscles in each area of the body. There's the lower leg, there's pelvis, there's low back, and then there's neck and shoulder. So it kind of covers a lot of the general kind of things, the things that people are going to see most frequently in clinic. But then the CMT classes are more specializing on each area. We're looking at, in January, we're either going to do the wrist or the neck. We haven't quite decided. So we're going to do one or other of those in January, so you can tune in for those. But yeah, you can go back and you can buy those past modules as well, which is a nice way of accessing those.
Well, it's a great way to access, because I mean, sometimes it's one of those things we go, well, heck, how am I going to do this? And people that are listening to this, then you can go, well, all right, well, I've got someone who's got, sacroiliitis, say, and then kind of flick back in and go look through the library and go, yes, there's something, now I know what to do about it. And it's because we don't have our access to the college as much as we used to. We can't kind of rip in and have a chat to our teacher anymore and say, listen, can you show me this technique?
Yes, absolutely. And we have some free articles on the website as well. I mentioned about writing an article for MMA's magazine on the knee, but we have one on subacromial impingement, because I've got a quite interesting take on subacromial impingement. I'm just looking, how do I post something in comments?
And we've got, I think you put it into the private chat and they can pop it into comments.
Okay.
That'd be the best way. Yes, and I was looking at that, talking about subacromial impingement. And like, because you said there's a few little bits and pieces, I thought, ooh.
Yeah. So we've got a free article that's got 3 short videos embedded in it as well. So that's on our website. I've just posted a link there into the private chat. So I'm presuming one of the guys will pop that into the public. And that article talks about my take on what is the biggest cause of shoulder pain. Any guesses, Paul? What do you think?
Biggest cause of shoulder pain? I would say
what muscle?
Be well,
See, most people are going to go for supraspinatus, right?
I'd probably go to subscapularis.
I would have thought that as well, but
biceps.
Actually, bicep.
Yeah.
Bicep is the big cause of shoulder pain, because what it does is when we get fascial adhesion at the distal end, when we go to straighten out our elbow, it actually acts like a sling. It drives the humeral head up. So it reduces the space between the humeral head and the acromion. This is what this whole article is about, but it also talks about how to test for it to see, is that what the person has? Then we talk about a little bit of treatment. It's only, because it's an article, there's only a little bit on treatment, but it suggests some treatment for bicep. And then there is home retraining as well. So when the humeral head gets driven up, it does affect all of the rotator cuff muscles. It particularly has a tendency to pinch the tendon of supraspinalis. And unfortunately, supraspinalis gets blamed for it. And supra's like, it wasn't me, because its tendon is getting pinched. We can get subacromial bursitis. We can get all kinds of limitation and pain. And what drew my attention to this first was people benching tend to get this a lot. And you're going, well, you're not really using supraspinalis when you bench, but it's this overdevelopment of bicep really drives the humeral head up. And then, of course, if we're overworking the pecs, we get this forward shoulder, the shifting in the angles of the scapula, the changed position of the glenohumeral joint, all those kind of things contribute. But bicep is actually the biggest driver. That I found when I started treating bicep, I was getting phenomenally better results with treating shoulder pain, regardless of which other muscles were involved. Treating bicep allowed me to drop the humeral head, which helps to normalize tone in all the other muscles. I would still treat subscapularis. I love doing pain-free subscap work.
Me too.
Sounds surprising for a lot of people. If you've had it dug out and you're like, no, it's really painful, there's a way to do it completely pain-free. That is phenomenal. I mean, you've had this experience with clients that get off the table and they're like, oh my God, that's amazing. They feel like their arm is just going to float away, like somebody's tied a balloon to it.
Yeah. And I've noticed a couple of times you've gone, and for people watching this, if they're thinking that I'm actually ignoring Aubrey, it's because that it's non-mirror image. So when I'm actually looking at him here, which means I think I'm looking away. So I'm not being rude to everybody. It's just that's the way it works. But I have noticed that, I'll be using this arm, I have noticed that you've been doing some myofascial glides at the biceps at that distal end, and absolutely we've been doing, I find, great results. And also looking at doing low load muscle activation at the two ends of the subscap, just to try to encourage it. Because as you said, inhibited, not probably doing its job independently. So
yeah. Well, those kind of low load ones are really interesting because it's oftentimes stimulating the GTO, the Golgi tendon organs, and that's been shown to have quite an effect on resetting muscle tone, not just in the target muscle, but in the surrounding musculature as well. So even like muscles like levator scapula that, in the early days of my training, I used to spend a lot of time, frictioning this terrible levator scapula, and then realized, oh, if you actually bring the shoulders back into a good position, levator's okay. And then you do a simple GTO release and it alters tone on all of the muscles that attach to the scapula. It's phenomenal. It's amazing, you can completely change tone. And people will talk about, oh, I have this terrible knot. I had one client who's like, El Diablo. This was the one that was killing them. And then you go, bring the shoulders back, and you go, now feel it. Oh, it's kind of gone.
Yeah. What pain? Where's it gone?
So that's those light bulb moments of treating. That's not a particularly complex condition, but it is in terms of the fact that in the early stages of your practice as a therapist, you tend to go where the pain is. And you'll treat levator, and it keeps coming back. It keeps being painful. And you're going, it's because it's under so much tensile load. Rubbing it is only a short-term solution. The long-term solution is balancing out the muscles so the scapula sits better and there isn't that tensile load on levator. Then it gets better.
Yep, exactly. So Libby's just put a little thing saying GTO release. She's wanting to see that Golgi tendon organ release.
Can
to
you
find
show us,
out.
Please? Okay. So hard to demonstrate this position. If you had a scapula with me, I would.
Not only does she want it, but she wants the particular target muscle.
She wants a demonstration of it. Okay. So I would have the client side lying on the table with the shoulder that I'm going to treat up, like towards the ceiling. You put your fingers kind of along the out on the acromion, the other one on almost like the inferior angle, and then your two thumbs are right on the attachment of levator. So from the root of the spine of the scapula to the superior angle, you're covering that entire attachment. The client then shrugs the shoulder. They pull up, and really for an effective GTO release, you want to be right on the tendon. So you're adding pressure to the tensile load, that mild load that Paula was talking about. So when they gently shrug their shoulder, you're pressing on the tendon. They do that for maybe 5 seconds. Doesn't even have to be as long as an MET. When they relax, the shoulder will drop a little bit more. They contract again for 5 seconds and relax. Contract, relax, contract, relax. And then you'll find that if you have treated, say, the pectoral muscles, you've treated bicep, you've allowed these muscles to come back, you've maybe done a bit of spindle stim work on the rhomboids and lower traps and mid traps. When you do that GTO release on levator, the shoulders just sit really well. You don't have to do any friction. I don't do any other treatment on levator because I think of it as being the victim in the scenario. It's not the cause. If you treat the other muscles, pressure comes off this, and the GTO release is just kind of the final step to normalize tone within levator.
Yeah, well
Hopefully
said.
that answers that, Libby.
And victim is absolutely right. There's a few victim muscles out there that we tend to abuse. So
we get in and beat up them. They're like, "Hey, I was trying to do my job. I'm the one that's being tortured here." Yeah, I know.
it's like people going up and down along the spine of like the erector spinae thoracically, and all they're doing is rubbing straight over a nerve plexus.
Yeah.
Oh, it's here, get harder, get harder.
Or even
Anyway.
sometimes the rib heads. People go, "Oh, there's a really hard knot here," and you're going, "That's a rib head." You're trying to break down bone. Not a good idea.
No, exactly. Talk to John Sharkey about that. That's his pet. Well, it's been an absolute pleasure. I can't believe the hour has just flown by. Is there anything else that we know that the therapists can jump in, and we've got the hcd.ie and follow Holistic College Dublin on Facebook. So we've got those links in there. We've also got a link down here that they had with regards to, where'd it go? It went the subacromial impingement. So they should be able to link into that.
Yeah.
And in a perfect world, people that want to get courses, virtual courses for Christmas presents, they can go on. In fact, people that you love, they can come in there and get them Christmas gifts of your courses.
Absolutely. And like those micro modules and the CTM modules, like I said, when you purchase those, you have access for life. It's different with some of our virtual seminars because we have intellectual property rights and stuff like that. If you sign up for one of our myoskeletal seminars, actually we've one coming up in January. Whitney Lowe is going to be our special guest. Actually, I know you talked to Whitney recently. You had a great interview with him. Whitney's going to be our special guest. If you sign up for that, you can join us live for the 3 days in January. I think it's a Friday, Saturday, Sunday. I think it's the 16th, 17th, 18th, something like that. It's on the website. But you get access to the recordings for 3 months afterwards as well.
Yeah.
So those are more kind of limited, whereas the other ones you get lifetime access.
Yeah. Tracy's asking, are you still planning to come to Australia in May? We're hoping so.
I am. Yes. That is the plan. We'll have to see because I don't think Australia has yet opened up its international borders. I think it's due to at the end of the year or something was the original.
We were supposed to until Omicron reared its ugly head. And
actually just read something this morning and they were saying that the WHO and one of the, I think it was the American, one of those authorities, CDC or something, were saying that they've investigated and they said Omicron isn't any more dangerous. So it's just a variant. It's not any worse. They feared that it was going to be much more severe or much more contagious, and they're saying it's actually not any different. So good news, hopefully there.
Yeah. Well, I was actually hoping if I was going to get, like, we're all going to get the virus at some stage and multiple times because it is as it is. But I thought if I have that Omicron, because I wouldn't mind a bit of fatigue for a day, because that apparently is about it, and maybe that will build up my natural resistance to some of the other nasties.
Yes,
anyway,
yes. So the plan is May.
Let everyone put out their hands on all you Aussies that are there going, we really want Aubrey to come back in, get to Australia versus doing a virtual. If it's not 22, maybe 23. I'm planning to get to Costa Rica with Libby in 2023. We're going to meet there and have a great time. Hopefully Eric might ask me to do some presenting, and that will help me on my journey to learn and catch everybody up.
Excellent.
And thank you everybody who's made comments. It's always helpful and engaging to get comments, and this will be out on all of our Facebook pages accessible for I don't know, a month or so, and then it'll be buried into the dust where they all go otherwise. But thank you again, Aubrey. It's been amazing. I'll let you go out into the sunshine.
It's pretty stormy here at the moment. It's pretty wintry. Yeah. The vague bit of tan I have is from Costa Rica. You can't even see it in this light, but people were commenting in class. So there's supposedly a bit of tan there. But yeah, I want to say a big thank you to you, Paula, for having me on, and thanks to everybody for joining us. Hopefully you found that interesting. So hopefully we'll talk to you soon, and hopefully be in Australia.
Thanks, everybody, and hopefully we'll catch up with you soon. Bye, everyone.